Hey, everybody. Looking forward to sharing this really crucial, critical information. Has implications not only for the short-term outcomes of the patients that we serve, but certainly the long-term health and wellness of the infants, their families, our communities, and our society at large. This is a profoundly relevant topic, and I am so honored that you guys are joining me today for this webinar. I'm going to take a pause while everybody gets settled, and we'll be starting in about 2 minutes. See you soon. Well, hello, everybody. Hi, my name is Mary Coughlin, and I want to thank you very much for you guys coming and spending this next hour with me to listen to this very relevant topic, suicide prevention in the NICU. Let's look at hospital-acquired conditions. The subject matter really was prompted by just an ever expanding body of research that's growing and showing us that the long-term survival of these individuals is complicated by a myriad of psychological pathologies, up to and including suicide and suicide attempts. We see this comorbidity initially present itself with a specific diagnosis in adolescence, but there's certainly some indicators in the earlier evaluations of these individuals at 2 years, 6 years, and on, that they may be at high risk for suicide ideation and actual suicide attempts. So I'm going to get started without any further ado. Who's joined us today? Please let me know who you are and where you're coming from. I'm hoping this can be a fairly interactive webinar. I know you don't have a microphone or anything, but we definitely have the chat room, which is always cool. Anyone want to share where they're from? I'm Mary. I'm from Boston. Okay. I think maybe folks are just starting to log in, get themselves situated. Hey, Amy, how are ya? Glad to see ya. Anyone else want to share who they are, where they're from? Grand Rapids. Awesome sauce. No pressure. I know many of you are probably doing this and doing other things while you're trying to pick up a little extra knowledge. So let's just get this show right on the road, okay? So my learning objectives for this learning session is to inform you guys of the inherent safety risks of hospitalized infants, and also kind of share some opportunities that we have with the existing value-based care model and CMS standards and the Joint Commission National Patient Safety Goals. Hi, Tricia from Savannah, to really position what we now know about the long-term morbidities as a really hardwired prevention strategy right from the NICU. And my other objective is to introduce you to and encourage you guys to join my tribe. And I'll explain the tribe a little bit later on in the session, okay? But first of all, I wanted to just kind of share with you the case for change. This graph here on the left is from a very recent publication, 2017, Johnson and Marlowe. And this duo has done a lot of work over the years looking at the mental health outcomes of infants that were born prematurely in the NICU. And this most recent paper was really fascinating because it really highlighted that indeed we are seeing these psychopathologies now in NICU survivors up to 30 years of age and beyond. And this information that we're discovering really needs to inform the clinicians that are caring for babies right now, right this moment, that will then allow them to transform the experience so that we can change these morbidities that we're seeing down the road for these infants. NICUs across the globe are saving babies that are smaller and smaller. And by smaller, it goes without saying that these individuals are also then that much more profoundly vulnerable and susceptible to many of the long-term complications that we're seeing in NICU survivors that have preceded them. This second chart, which I really like how the authors, Johnson and Marlowe, really juxtapose these findings with their concern for the future for these NICU survivors. The graph on the right is from a paper that was published in 2009. It was a study that was done in Sweden. So it was a national focused cohort, but they're really the only folks that have looked at this in a very discrete way, where they have correlated gestational age with psychological pathology. And I know for many NICU clinicians, an understanding of psychological pathology may be just a distant memory. We know it's bad, but sometimes we don't really connect personally with how bad is it. We just know it's bad. And I just want to kind of elucidate what that really means. Having psychopathology is a game changer. It alters not only the developmental trajectory, but the human potential for these individuals. It compromises the quality of life. It is a minute by minute, day to day struggle for these individuals and families to stay grounded. And one of the things that we're discovering about why these survivors are so vulnerable for these psychopathologies, it really is connected to that early trauma, that early toxic stress that these individuals endure during the NICU stay. And if you've heard me speak before, you won't be surprised when I tell you that the number one stressor, the number one toxic experience that these individuals experience is separation from their parents. And it's interesting, that we're now in a time where there's national and international outrage about these poor families, these poor migrant families at our borders, and all the outrage about separating children from their parents. And it should be outrageous. There should be outrage about this. It absolutely is child abuse. But I want you to take that passion and that energy and that spotlight on that actual phenomenon, where the president of the American Academy of Pediatrics now is actually saying this is tantamount to child abuse. We do know that this has a long-term negative impact on the developing infant. Take that understanding and now apply it onto these profoundly vulnerable individuals that are premature, that are experiencing this toxic stress during critical and sensitive periods of development, right? Remember the work by Ruth Feldman, who very beautifully and elegantly elucidated the vulnerabilities of the developing brain at cellular, molecular, and now even genetic, at a genetic level. And so, if separation from the parent, no matter how short or long, any kind of separation, particularly during that perinatal period, can have profound lifelong lasting implications. I apologize. I get a little bit nervous at the beginning of my webinar, so I'm getting all tongue-tied because there's so much information I want to share with you. And yet that's really the challenge, right, is that there is a degree of separation that occurs because the infant is thrown into this life-threatening situation. And every single minute that passes, clinicians really need to be challenged with how are we going to resolve this as quickly as possible? If you remember the work of Niels Bergman, where he talks about really moving to zero separation. You know, I mean, I think he does focus to some degree on the healthy mother-infant dyad, but it's not mutually exclusive. Just because you're sick or premature doesn't mean the rules don't apply biologically. They absolutely apply. And to some extent, they're even that much more relevant, because we're seeing that there's a lifelong implication for this separation. And the longer the separation goes on, it not only deranges the infant's developmental trajectory, but it also compromises parental role identity and parental confidence. I hear many parents say that their babies may be in the NICU for weeks, but it isn't until they actually hold that baby skin to skin that they actually feel like a parent. And so we really need to listen to this and have that inform the way we're approaching care, the way we're partnering with parents, because the long-term outcomes are devastating. That's probably the best word that I can use. Johnson and Marlowe go on to describe that we are now seeing a very clear behavioral phenotype of preterm infants characterized by changes in their attention, anxiety, and social difficulties, and that their prevalence estimates for psychiatric disorders are more consistent at 23% to 24%, equating to 3 times an increased risk for premature babies when compared to their full-term counterparts. I mean, this is significant, and it originates at that neurobiological level, where the brain is expecting certain experiences to stimulate certain synaptic progressions and wirings and connections. And when those neuronal networks are not stimulated, they don't receive the right input, then they wither away and die, right? Neurons that fire together, wire together. That's Hebb's law. And so what gets wired together are those experiences in the NICU that quite often are aberrant for long-term social and emotional health and wellness. These infants are exposed to repeated overstimulation, pain, undermanaged pain or unmanaged pain, excessive sensory stimulation, a sense of isolation that translates at the level of the amygdala and the brainstem as terror, fear. And what that does is it primes the autonomic nervous system. It primes the vagal system to be hypervigilant, to be hyperactivated. And all of that process then, right? So think about the HPA axis. Your hypothalamic pituitary adrenal axis is your stress response system. Your stress response system is activated when there is a stressor. If you've heard me speak before, I'm not trying to infer that all stress is bad, but think about what I'm saying within the context of the NICU. The stress that they experience, they attempt to adapt, but in the absence of the presence of the buffering effects of maternal care, they are unable to adapt. They are unable to tolerate what is happening to them. The stressor, whatever it is, whether it's environmental, procedural, whatever, overwhelms the organism's ability to cope. And so the HPA axis goes into overdrive. And when you think HPA axis, don't think just cortisol, because it's not just cortisol. It's a myriad of other inflammatory mediators and catecholamines. And what happens is in the NICU, the stress you don't just get hit with stress and then it all goes away in a very short period of time, and you can just be calm and cool and chill and not worry about anything bad happening to you again. Bad stuff happens in the NICU minute by minute, day by day. I mean, it depends on your severity of illness and all these other kind of things. So what happens to the HPA axis response is there's an initial acute activation, and then it transitions into a chronic state. And chronic state stress is also a contributing factor to the derangement that we see in homeostatic integrity, in how neurons and other brain systems are wired, also how our physiology responds and adapts and grows. Because again, remember, as I said just a few minutes ago, all of these events are occurring while the individual is still developing. They're still laying down new tissue. They're still building mass. They're still laying down new neuronal networks. So what happens when there's this chronic state of stress is it's followed by or accompanied with this chronic state of inflammation. And this chronic state of inflammation actually starts degrading cellular function, cellular integrity. There's this really amazing researcher, Bruce McEwen. He's a neurophysiologist who did a lot of work about the impact of stress and the stress that I'm talking about, toxic stress, in adult ICU patients. And what he found was that there was a correlation with the stress that they experienced because of their isolation, because of crazy visiting hours and all this other crazy stuff that we do to sick people because we think it's in their best interest, but in fact it's not. It actually was associated with an increased risk for infection, a longer length of hospital stay, delayed tissue healing, and all that kind of stuff. And so it's a very grounded and kind of tried and true model. So a nurse researcher who focuses in neonatology has taken his model and is now applying it to the premature infant and has kind of put forth this conceptual idea that, all right, if this is in adults and we are all human organisms, I wonder if there's some correlation. And she's done further studies, but what I want to share with you is her overall model is how this idea of stress or allostasis, so that's the fancy word for stress, how does allostasis and subsequent allostatic load, too much stress, contribute to other diseases that are mediated by inflammation? And what are those diseases that are mediated by inflammation? Well, we've got lung disease, we've got retinopathy of prematurity, we've got intraventricular hemorrhage, we have neck for sure. And so how is it that when we are not consistently and reliably managing the stress that these individuals experience during hospitalization, how much that is then actually undermining their health and wellness? Because if you think about homeostasis, right? Homeostasis is everything's nice and even and swell. Homeostasis is the thing that's, keeping you guys keeping your eyes open and breathing while you're listening to me and just keeping the engine humming. When you start hitting it with allostasis, all right, on first blush, it's not so bad. I had an allostatic hit when I started this webinar because I get a little bit nervous. And so what it does is it revs me up and it gets my engine kind of cranked at a higher level so I can be energized and hopefully engaging to share this with you. But if I kept getting banged with more stress, there would be a breaking point where the stress then is so overwhelming, it actually starts separating and disturbing homeostatic integrity, which disrupts cellular function, physiology, and all that kind of stuff. And that's what happens in these individuals over time. We generally tend to focus on the outgrowth of that from a physiologic perspective and look at some of the medical morbidities that are associated. But what's really striking is the psycho-socio-emotional morbidities that we're seeing in these individuals that absolutely are easily managed and quite possibly mitigated by parental proximity. And not just in the room, but actually physically at the baby's bedside, working with the baby, doing the cares. You look at the results of the FICARE, the Family Integrated Care movement up in Canada, and it's slowly creeping down into the US and over into the EU. We're seeing dramatic improvements, albeit they haven't looked at the long-term psycho-socio-emotional outcomes of the cohorts. It's too soon to say. But even in the short term, when we look at the work of Monterosi and his team, this is the researcher from Milan, Italy, who looked at the quality of developmental care and its implications on a cohort from birth out to 5 years of age. What we saw is the babies that were cared for in NICUs that had high quality developmental care had better outcomes at discharge. It's all statistically significant. At discharge, at 3 years of age, language skill acquisition equivalent to their term counterpart, and at 5 years of age, they had health quality related outcomes that were also equivalent to their same age groups. At 2 years of age, at 18 months to 24 months, the babies that received poor quality of developmental care had a higher incidence, and particularly poor pain management specifically, had a higher incidence of internalizing and externalizing behaviors. And we've seen this reported before. I'm actually going to advance to my next slide. Oh, no, I'm not, because I'm getting ahead of myself. That internalizing and externalizing behaviors, those are precursors to anxiety disorder, to depression. They can also be linked to oppositional defiance disorder, which we see in adolescence, which is generally accompanied by anxiety disorders, and so on and so forth. So we are seeing these behavioral perturbations that indeed Johnson and Marlowe are now describing as a phenotypic expression of survivors of extreme prematurity. You can see this graph on the right here. Let me just bring you back to the work of the Swedish team. Your odds ratio, when the odds ratio is at 1, it's basically telling you that there's no correlation between the two things that you're looking at. So here we're looking at gestational age and we're looking at psychomorbidities. But when your odds ratio is greater than 1, which you can see across as the predominating odds ratio for all of these pathologies, you can see that there is indeed a correlation. And of course, the higher the number, the higher the correlation. So we're seeing organic neuropsychiatric disorders, stress-related disorders, and suicide ideations, attempts, and sometimes even successful attempts. There's a really excellent paper by Blaskow and Flanowski. I apologize, but I did put the paper in a special folder for you guys that I'll share at the end of this, who talked about the dramatic increase risk in adolescents who are born prematurely for suicide attempts. So this is a real phenomenon that we need to grab onto and change quickly before any more lives are lost. This is serious business. Again, Nosardi et al. Did this beautiful review looking at the risk of psychomorbidities in premature people. And what he discovered is the more premature you are, the higher your risk. And he was looking at non-affective psychoses, with schizophrenia being the predominant non-affective psychotic disorder, depressive disorders, and bipolar disorders. And I had the supreme privilege of presenting a little while ago with a group of parents of former premature people at a conference, and they shared stories of their children and their experiences with depression and anxiety disorders. And I think this is something that NICU clinicians really need to bear witness to. It's one thing to look at the patients that we're caring for and how adorable they look in their little bunting, and everybody's so happy that they survived. And survival obviously is super important, but I think survival, it needs to be balanced with how well have we done in supporting a thriving future for these individuals. The parents had their children, they interviewed their children and did a little video take on it. And it was so amazing to listen to these children share the suffering that they endured during their more intensive bouts with depression and anxiety. And they were so frank and honest and raw about it. It really, I know it touched everybody in the room who heard it. I think more and more people need to hear it. This is a testament to how we've impacted these individuals. It's not enough for us to say that we've cured them or we've helped them get through their acute illness of their medical condition. We need to be more tuned into the emotional trauma that they're enduring during their NICU stay by us, having these ridiculous policies for keeping parents away from their babies. And a lot of it is based on the fact that we're afraid or we're concerned or we make up stuff. Oops, I'm sorry, I'm getting too energized here, but we need to change the tide. And we have opportunities with the Joint Commission and CMS standards and this new approach, it's not new, but new to us, relatively speaking, to change how we are going to be addressing and highlighting better care for these infants during their NICU stay. The risk of violent suicide attempts, this was the paper I was mentioning earlier, Blasco Fonticelli, is dramatically increased in infants that are born premature. And so what does this mean for us? What this means for us is that we need to examine, we understand now what the mechanism is. It's toxic stress. So then we need to dissect what is causing this toxic stress response. And as I said earlier, the number one trauma or toxic stress experience or early life adversity, these are all different jargons for the same core meaning. It's a traumatic experience for an infant to be separated from their parent. We need to mitigate and manage that. We need to get to zero, because what this does is it deranges the child's development. Yes, you know, if there's a reuniting of the parents with the infant, yes, we can minimize the long-term damage, but don't be fooled, okay? There has been changes. Changes have occurred. Neuronal networks have been rewired because of the acute event, that acute disruption. Think about the fetus in utero. They're literally fully surrounded by their mother, right? Not just physically, but from a sensorial perspective, from a smell, from a taste, from a feel, from a sound, everything. The baby is literally being bathed in the full experience of being with mom and what that feels like. And in a healthy situation, as the transition to the extrauterine world begins and is culminated, that sensory experience takes on a new dimension. I'm not now surrounded by my mother, but now I learn the external environment of my mom and my parents. And what does that smell like? What does that look like? What does that feel like? Not only, you know, kind of like from a discrete sensory experience, but how does it make me feel as a new human being? Do I feel safe? Do I feel secure? Do I feel connected? Do I feel loved? Because if I have that, even in the setting of bad things happening, I know I can get through those bad things because I am with those people or that individual that conveys that sense of calm, love, connection. And it translates to my autonomic nervous system that, you know, then stays in check, because maybe I can go up a little bit, but, you know, I can feel how my parents are responding to the situation. But as long as I'm with them, I'm okay. But we don't do that. We wrench them. We get all jacked up on the adrenaline that's going down. And please know, I didn't just fall off the turnip truck. I know it can be scary. I know it's wicked important. I know that lives are at risk here. We need to do a better job at preparing parents for this as best as possible, but in a deliberate way, not in this half-assed way that we do, kind of like flying from the, you know, from our seat and, you know, kind of giving them the lowdown while they're still shell-shocked that something really bad just happened. There's lots of parents that are anticipating a premature delivery. How do we, you know, get them into a place where, okay, this is what's going to happen. This is what we need you to do. Let's do a dry run. Here we're at the warming table where your baby is going to be brought and lots of hands are going to be on your baby. This is what's going to be happening. And your whole job, you know, parent, whoever that other person is to speak reassuringly to the baby, maybe hold them here. But if we, you know, we have to move your hands, whatever. I mean, but you could do these dry runs. There are different ways that we can approach this. We don't, you know, you don't do the same thing for 30 years or forever and expect a different result. You know, that's crazy. We need to really be deliberate about this, and we need to partner with parents who have gone through this journey to help inform us, you know, what could have been differently, not just in the moment, but in the preparation stage, if it's a possibility, but also have kind of a plan B. If there isn't that preparation phase, then somebody on the healthcare team needs to be assigned to comforting that baby, focusing on what that infant is experiencing. You know, I know people will say, well, we don't know what they're feeling. You know, do they really feel the same as a grown-up? Do you really want to take the risk of assuming that they're not going to have a shared human experience to a life-threatening intervention? When you talk to grown-ups who are resuscitated at the scene from like a motor vehicle accident, they're very clear in expressing what it felt like, the terror, the fear, the confusion, the disorientation, and how the EMS people or the grown-up care providers spoke to them and tried to connect to them. But of course, we're very busy. You need to have somebody dedicated there to reassure them, particularly these incredibly fragile individuals. We can change this trajectory. And the number one, the secret sauce to this is the parent. It's that love. It's that connectedness. We need to figure out how to do it better. Even in the acute event, we talk about the golden hour. There's now check out the website for the golden 1,000 days, those first 2 years of life. But it starts at the beginning. That cascade of hyperactivation of the HPA axis begins at minute 1, at second 1. And so how can we reshape and reorient how we are responding to the resuscitation and then the ongoing care of these individuals? We need to have a dramatic paradigm shift. And that dramatic paradigm shift, at least from my perspective, is built on the good work of so many people who have come before me, Dr. Al's, all of the, advanced nurses that have really looked at this idea of developmental care, Jean Watson, the theory of human caring, Florence Nightingale, right? As nurses and, other specialists, but I generally default to my nursing hat, we're responsible for managing the human experience of disease. And it's not like when the patient's stable. It needs to be from admission, from minute 1. We need to manage the human experience in conjunction with their medical needs. So there needs to be that shift. And I think we're poised now that the jargon is available to us to now connect the dots of why this is so biologically and clinically relevant to the bean counters, to the C-suite folks, based off of this concept now that you hear a lot of people talking about, this idea of value-based healthcare. Value-based healthcare is a healthcare delivery model in which providers, including hospitals and physicians, are paid based on patient health outcomes. Historically, folks have been paid, it's been a fee for service. I give you an IV, I charge for the IV. I put an O2 sat monitor on you, I charge for the O2 sat. I put an ET tube in you, I charge for the ET2 sat. And then, we have that middle ground where we also then pay for, you have respiratory distress syndrome, I get a charge for that. But now the movement is really saying, if you screw up, I'm just going to talk plain here, okay? If you screw up in taking care of me, then you don't get all of that money. You don't get all of the perks. And, some of the perks now are being recognized as very important. Yes, you're saving my life, but I got a hospital-acquired infection. Thank you very much. And why did I get a hospital-acquired infection? And, you really start peeling back the layers. Well, the number one link to hospital-acquired infection is poor hand hygiene. We look at CODIs, catheter-associated infections. We look at ventilator-associated pneumonias. We look at all of these other things that I'm going to share in a few slides. And those are really going to inform what your reimbursement is. So that's kind of the grown-up world, all right, or the older patient population world. But the outcomes for our patient population are a little bit less obvious, right? I mean, yes, we have CODIs, catheter-associated infections and ventilators and tubes, what do you call them? Line-associated infections and stuff like that. But there's so much more to our patient outcomes, right, than just those kind of short-term things that disrupt and prolong the hospital course. We see long-term outcomes in these individuals as what I've just described. We're seeing psychological pathology. We're seeing behavioral challenges. We're seeing emotion regulatory problems, sensory integration. And oh, by the way, these morbidities, if you will, they get categorized incredibly inhumanely, in my opinion, as minor morbidities. And I'm here to tell you, suicide is not a minor morbidity. Schizophrenia is not a minor morbidity. Anxiety, depression, these are not minor complications to my life. They are quality of life busters. And I really feel that we are poised to really represent our patient population and advocate for them in a meaningful way. What I've discovered as I've really been digging into this topic is that the folks that are really kind of writing these recommendations and these guidelines and these ICD-10 codes and all of this kind of stuff, they're basically generalists. They're grown-up specialists, because I'm not really seeing a lot of neonatal specific information that is really relevant and could really turn the tide on how we are looking at a prevention-oriented model of care for the neonate. And I'm sure you're all familiar with, the work that's been published about looking at the fetal and neonatal origins of adult disease. Well, we now know, based on the adverse childhood experience study and the work now of Monterosi, categorizing premature birth as an early life adversity and what that means for the lifelong health and wellness of these individuals, is that these folks are at higher risk for cardiovascular disease, hepatitis, chronic lung disease, chronic pulmonary chronic obstructive pulmonary disease. They're also at a higher risk for suicide. They're at a higher risk for alcoholism. They're at a higher risk for IV drug use. I mean, from having early life adversity. And that's not just in the hospital, right? Medical trauma is one kind of compartment of the overall bundle of early life adversity or early life traumas that individuals experience. There's also physical and emotional abuse, family dysfunction, and all of these other things. But looking at it from a medical trauma perspective, there are metrics that could really measure the quality or the value of the care that we're providing these individuals, not just in the short term, but in the long term. And I really think we collectively need to put a voice to this in a really meaningful way. These hospital-acquired conditions really kind of, got the attention of the American healthcare system because there's more money, more costs associated with it, right? So hospital-acquired conditions are high cost or high volume or both. They result in an additional DRG or diagnosis-related group, which means a higher payment is made on behalf of the patient as it is added to as a secondary diagnosis, right? So if you come to the hospital because you're premature, that's one diagnosis. And then you get an infection, that's another diagnosis. And then you get hyperglycemia, that's another diagnosis. And then you get chronic lung disease, that's another diagnosis. And then, but we stop, and then you get a line infection, and all this other kind of stuff. But we basically stop right there in those tangible conditions. But I really, really feel that there's an opportunity for us to challenge the current paradigm and say, wait a minute, we need to also follow out these individuals, examine them at 2 years, examine them, continuously. And when you start seeing perturbations in their behavioral phenotype or their behavioral expressions or their way they're comporting themselves and interacting with the world, then that also needs to be the folks need to be held responsible for that. Or at the very least, let's examine a change in the paradigm to really mitigate this separation and bring it to zero and see, does this really make a difference? I believe it really will make a difference based on everything that I'm reading. That's my very strong hypothesis. And I'm inviting you guys to come with me on this journey, join the tribe and look and see, can we do things differently? Should we do things differently? And how do we hold clinicians, providers, and organizations responsible then for making sure that these evidence-based best practices are really operationalized? Because look at this, that's bullet number 3. Could these hospital-acquired conditions been reasonably prevented through the application of evidence-based guidelines? And guess what? We have evidence-based guidelines. We have evidence-based guidelines for all of the medical diseases, but we also have the 2016 evidence-based guidelines for trauma-informed neuroprotective care that have been endorsed by the National Association of Neonatal Nurses. And also recommended by the National Association of Neonatal Therapists. They also have the blessing of Dr. Heidelise Als. So I think, the time is now for us to really address this. I think, I've been doing a lot of work individually with clinicians and hospitals, to try and speak out about this. And I'm very grateful for all the opportunities that I have, but I cannot do this alone. And I need you guys. You guys are spending your Friday afternoon with me. I know this is meaningful to you. So let's get together. Let's do something about this. Let's at least explore, is there an opportunity to do it differently? And connect with Joint Commission, connect with CMS, connect with, my last slide, the National Quality Forum, and start drafting things that are going to make a meaningful difference, because it's really important. So these are the hospital-acquired conditions. There's 14 of them that are listed on the as ICD-10 codes. And those are like the codes that get folks money, right? They reimbursements. And is a myriad of list here, but a myriad of different things on the list. And let me tell you, there's a laundry list of subcategories underneath all of these main headings, okay? But the one that I want to bring you to is here on the first column. Can you see where I have falls and trauma? Well, when I was looking at that, so the falls and trauma includes fractures, dislocations, intracranial injuries. I believe it's assumed that they're a result of the falls. Crushing injuries, I believe also as a result of the falls. Then it goes into burns, frostbite, and then there's this like kind of generic term of other injuries. In that heading, there was 3,730 ICD-10 codes under that heading. But again, they're looking at all of these things that have nothing to do with the neonatal patient population. I really feel like this is an opportunity for us to make a contribution. What are those other traumas that kind of fall under that other injuries title? We know what they are. We're seeing the data. And yes, we have to do additional work, but there are lots of researchers out there. The team in Italy are continuing to look at this phenomenon of early life adversity associated with prematurity. They're doing some amazing work. I know there's lots of U.S. researchers as well that are specific to this. Amy DeGata is one, Sharon Cassavan, lots of really amazing folks. I mean, obviously the NIDCAP organization, looking at how we can address this in a meaningful way and put some meat on this. It's not enough. I mean, we know this. It's not enough that we know and that we as individuals try and do the good work that we do, because we still have our negative Nellies. We have our naysayers across all disciplines that are still, well, we don't believe that, or the research isn't good enough, and blah, 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 blah. These are fellow human beings. It's not that I'm dismissing the importance of research. I get it. But do I really have to research what's appropriate? Or do I have to validate that providing love to a newborn infant has biological relevance? Do I have to really research that? Do I have to prove that in a randomized controlled trial? I mean, I hope I don't sound crazy, but I'm really, really frustrated with the current state of affairs and feel like it's time. It's time to start a movement. It's time to start a tribe and collectively make a difference in this. The Joint Commission. So every year, the Joint Commission started this National Patient Safety Goal thing back at, I want to say, fudge, in the early 2000s, okay? And they basically looked at the things that really were safety goals, right? They were process things and stuff that we could put in place that would reduce bad things happening to patients, right? So, and many of these that you see here on the board, these are the 2018 National Patient Safety Goals. They're pretty much the same ones that have been there for like at least 5 years, if not longer, okay? So identify patients correctly. Underneath each one of these, on their sheet, there's like lots of sub qualifiers and stuff like that. Like you should have 2 people, you should have a band and stuff like that. Improving staff communication, that patient safety goal is specific to reporting critical lab results, because they were finding that there were issues around lab results that were compromising patient safety, and bad things were happening to the patient because people didn't report it, all that kind of stuff. Alarm safety, that's up there because of all the issues around alarm fatigue. People literally dying because people are tuning out alarms because the alarms are going off all the time and there's all these nuisance alarms. So that's a national patient safety goal. It has the attention of everybody should be, kind of focused on how are we going to deal with these things. Preventing infection seems pretty obvious. I'm going to jump the dark blue one for a second. Preventing mistakes in surgery is obvious. And if you remember from the previous slide, looking at hospital-acquired conditions, there was a ton of stuff about surgery stuff, from not doing the right antiseptic stuff to leaving stuff inside the patient. Obviously, we need to do this. Coming back to the blue one, the second from the last, identifying patient safety risks. The qualifier for that is that we identify patients at risk for suicide in psychiatric settings. So if you're at risk for suicide, but you're not in a psychiatric setting, you're in a med-surg floor or something like that, apparently it doesn't seem like it's as big of a deal. But it's a qualifier. It was a qualifier that somebody said, okay, under that heading, here you go, because this is a big deal. And I'll be honest with you, it is a big deal. All right. Patients in psychiatric settings do try suicide, and it is very terrifying. And it's an absolute ICU kind of a situation. But none of these have a sub-qualifier specific to the neonate. But let's look at identifying patient safety risks to the neonate. I mean, what do you guys think? What are some safety risks based on the psychosocioemotional stuff that I just shared with you? They're those are the safety risks that they're going to have compromised mental health. They're going to have compromised behavioral expressions. They're going to have compromised emotion regulatory capacity, sensory integration. And so we've identified them. You're in the NICU. This is who you are. You are at risk for this. And so then it, kind of flips over to then the compelling thing then that we have to do to address that, to mitigate and minimize the risk. We have to be smart about our developmental care initiatives and connect them to agendas that go well beyond the NICU, go well beyond our organization, go national, go international. I mean, you can look at the WHO, the World Health Organization, makes recommendations for zero separation, makes recommendation for breastfeeding, consistent breastfeeding. And yet, we know that the first breastfeed, to a mother who says she wants to breastfeed her premature baby, the first oral feeding then should be at the breast. Is it? No. Not consistently. I mean, there are a handful of people that do it, but it's not a consistent standard. Why? Why is that? Because nobody's holding folks accountable. I'm just calling it like it is, guys, and I'm a little bit aggravated. I'm a little bit frustrated because this is just too important. If we could save one life, right? How amazing would that be? And we need to do that. We need to own that morbidity. We need to own that long-term outcome. The value in the value-based care is the outcome divided by the cost for that outcome. And the things that I'm talking about cost nothing. I'm talking about, maybe it costs some time. Maybe there are a few dollars, to have some extra staff, do some real formal education, create some real innovative ways of engaging parents even before the delivery, if possible, or family, because the parents may be like literally in crisis. Can we connect with other family members and then reconnect with the families when they're in a calm state, But we need to engage the network, their neighborhood, their community, in meaningful ways. So whatever the cost is associated with that, it's not obscene. It's not the cost of a giraffe incubator. I can tell you that. And the benefits far outweigh those minuscule costs. Outcome is looking at quality, efficacy, and safety. Those are the aims. Those are the overarching aims from the Institute of Medicine about what constitutes quality in healthcare. It's efficacy, it's safety, it's timeliness. And there's a whole bunch of other ones that are escaping me right now. But we need to do this in a meaningful way. And so, as I kind of come, to a close on this, I want to kind of offer this up, all right? The value proposition then of trauma-informed neuroprotective care for infants and families. We know that toxic stress is a mediator between early childhood adversity and suboptimal outcomes in learning, behavior, and health, both physical and mental. We know social, supportive, and nurturing interactions counteract the stress response and can cultivate resilience. And so by understanding the biology and the neurobiology underlying early life stress and social interactions, then opens up new opportunities for us to get super creative about primary prevention strategies and earlier interventions. Early intervention is awesome, but we need earlier interventions that begin on admission, focused on primary prevention for that infant family dyad. And I hope you believe me when I say, if we do this, take it back, retract. When we do this right, it will feel so good. It will feel so amazing that you're doing the good work that you've always wanted to do. Being an ICU clinician is more than being an adrenaline junkie. It's taking care of the wholeness of the person. If you're really on the right seat on the bus, that's what it's all about. You can train anybody to run the equipment, to titrate lines, to turn knobs, to look at machines and turn it for this and turn it for that. You don't have to have a degree or anything special to do that. The thing that our advanced education brings us is the wisdom and understanding about the complexity and the dynamic nature of what it is to be human and what it is to be present and bearing witness to the most tragic thing that can happen to a family and try and make it less tragic in some way. Because out of these tragedies, right, it's like the phoenix arising, you know. There is a beauty that comes when families get discharged, and we don't have to have them worry horrifically about a lifelong legacy of their NICU experience and how it has changed everything. It's going to change things, but can it change things in a way that families are more prepared for, more informed about, and that really do have a less of a lifelong deviation from what could have been in their life. Now, all of this is what I'm inviting you to do and what I'm asking you to do is certainly it's not easy, right? But if it was easy, everybody would be doing it already. Reducing this global burden of preterm birth and the premature morbidities really gets hung up at what is now being called the knowledge transfer exchange, and that's just fancy words, really. It's when I talk about minding the gap, it's the gap between what we know and what we do. We are awesome at doing to babies. We do things to them all the time. We do things to families all the time. We need to change that to doing things with. But the things that we do with them need to be informed by best practice. And I don't know if you guys are familiar with this, but there's a huge gap. There's a huge lag between what is known and what is known and applied in clinical practice. Like the first paper that I found, I'm sure there's many others, from Johnson and Malo, was written in 2011. And the more recent one that I pulled the graph out of was 2017. But folks have been talking about the psycho-emotional morbidities of premature infants, of NICU survivors, for a decade. And this information I still share this information, and my NICU colleagues are like, wow, I never knew that. And it's fine. I mean, I certainly, you don't know what you don't know, and I get it. And so what I'm inviting folks to do with this tribe movement is to begin to network, create this grassroots, but we're all connected and we're learning from each other about how to send that out, how to send that information out, how to inform to empower that then transforms. It's, knowledge transfer is not a linear phenomenon. We come at it with, all these different ways. We have to be clever about it. We have to be engaging about it. If you're expecting everybody to learn everything they need to know about neonatology at a conference, you are in for a big disappointment, all right? I mean, and the other bit of it is all of this knowledge, it's not all in your go-to NICU journal. I mean, I subscribe to Advances. I get Neonatal Network, but the stuff that I'm finding here is in, archives of diseases in psychology. It's in archives of childhood diseases. It's in infant mental health. It's in, this one was in an education journal. I apologize, I'm a brain fart here because I'm talking too much, and I'm just so energized about this because the opportunity is there. There's a large enough body of people that get it, that understand that we can change things. I mean, the three key reasons for slow progress is, besides so the number one is like, we don't understand why prematurity happens. So that's kind of putting the, gumming up the works. There's, lots of different evidence-based interventions, but not everybody adopts them. So that's another sticky wicket. But again, the big thing is the no-do gap. And it's really been that major obstacle. And I feel like if we can get a bigger network out there, a grassroots network going on this, maybe we could change the tide and then collectively start defining what are those quality measures that inform hospital-acquired conditions, that inform what are the safety risks that are inherent in the NICU patient population. And so what this joining the tribe thing is all about is I put together this little workbook. It's a blueprint for trauma-informed care. I've also included this. It's a 1.5 hour, so full length, buckle up, training video on hot topics in trauma-informed critical caring. And then, but the real magic is the lifetime access to the tribe. It's a closed Facebook group where I will make a weekly post, whether it's article, video, or something cool that I find, to stimulate discussion, start problem solving, and really start the discussion about where do we go from here? What are your thoughts about this? I'll pull it together. You guys give me the input. Let's do this good work. The fee for this is it's a $47 single enrollment, all right? And then this is what you get. The blueprint you can download immediately. The video, because it's so wicked long, it's a really big file. Once I get your information, we'll send you, we'll share the Dropbox folder with you. I've got other stuff in the folder as well. And then we'll send you an invite to the Facebook page. But what I'm hoping that this work will do, in getting a tribe together, is I don't know how many of you guys are familiar with this National Quality Forum, but the National Quality Forum's mission is to lead national collaboration that's aimed at improving health and healthcare quality through measurement. And so what they do is they create what are these quality measures? What are these quality indicators? And then this information then informs the Joint Commission. It informs CMS, and it also is part of the standalone National Quality Forum. They strive to achieve the mission by, this is what they're doing. And I would like to be one of those collaboratives that can make these kinds of contributions, but I can't do it alone. I need a network of folks. I need a tribe of folks that are really as passionate as I am about this. And that's really what a tribe is, right? A tribe is a group of people that are passionate about the same thing, that have a shared commitment, that this activity, this action, it's heart-centered, it's purpose-driven, convening key public and private sector leaders and groups to establish national priorities. And that's what we can do. I mean, I know, you've got the March of Dimes, there are other organizations out there, and they're doing this. March of Dimes is focused on eliminating premature birth. And it's an admirable, noble commitment. But, where are we at then with the babies that are born premature? Is there an opportunity for us? And overlap is good, right? I mean, if we're resonating with other voices out there and there's some intersection with us, right, then our tribe becomes part of a larger village to inform governments, to inform agencies that will then compel our hospital organizations, compel our units, compel our colleagues. And we can hit it from both ways, from an inside person sharing and role modeling what is best practice. But we need that external pressure as well to guide and drive it and to be informed, working to ensure that these standards will be primary standards to measure and report on these quality outcomes and the efficiencies that result from it. These efficiencies, not just from the workflow at the front line, but the efficiencies that happen at the societal level. If we can reduce the psychomorbidity associated with prematurity, we're just opening up a more fuller potential of these individuals' lives and their families' lives to be the full family that they wanted, the full individuals that they were hoping to be. So, I completely jumped on my own bandwagon and soapbox, but I'm hoping that we get, good folks. And, there's no number to this, okay? I mean, I can do this with one, I can do this with 100, I can do this with 1 million. I'm just really looking for folks that that are as passionate about this as I am to do something great and join the tribe, and let's start changing the tide. Let's start really being a true voice, not just at the front line or at the local level, but at the national and international level as well for the people that we serve. Let's not look at just the short-term outcomes, which are important, but the longer-term outcomes that really make and shape the families, these individuals, and our society at large. So I hope this was informative. I hope it was engaging, and we've got 3 minutes left on the clock, and I'd really like to open it up to you guys to just ask me questions. Type them in the chat box. And you can, and I love constructive feedback. I welcome your most critical thoughts and ideas and questions. Go. As you hear me gulp. No questions, huh? No comments? I'll be sure to add you to the distribution list and the contact list, Wendy, but please think about joining the tribe, sharing this. Thank you for bringing this topic to light. Absolutely, Amy. It's really important. It was really a profound experience presenting with you guys in Chad. It's really impacted me in a real meaningful way. So thanks. I'm happy to share the slide deck with you guys if you like. I certainly don't want to clog up your mailboxes, but if you are interested in it, here I'll put my email address up there. If you'd like it, if you have any questions after the call, please feel free to shoot me an email. This is my passion. This is my purpose, and I believe this is why I'm here to serve. So, God love you. Thanks for the presentation. Quick question: do you have a process that, as you collect data, to have a report or review option? Do you have a process that, as you collect data, to have and report or review option with the joint? I haven't worked that out yet. No, absolutely, Aim. I'll set it out. So that's also part of the process. I have tried to reach out to the Joint Commission in the past, and one of their challenges is the bandwidth in addressing this. So that was another kind of spur for me to then think about then how can we kind of put something together. So I will be working on that. If you have any ideas or if you have any resources, I would welcome any input that you have. I feel like right now, in the beginning stages of the tribe, it'll basically just be kind of leveling the playing field, sharing information, seeing what you guys' thoughts are about this information. I would absolutely love to connect with pediatric associations. Again, I feel like right now I'm at the baby steps of this. Once I kind of get a little bit more meat behind this, I definitely want to reach out. I know that the National Perinatal Association is an amazing organization really focused on parental mental health, which is obviously very important as well. And I also, I feel like this initiative in addressing the infant's mental health will go, because the parent is the magic bullet, they're the secret sauce to this. It would also help the parent's mental health. So there's a lot of work that needs to be done, but I really kind of want to reach out and just, get a sense of the level of engagement. What's the level of commitment? Thank you so very much. It's not easy, but you know what? It's that's okay. It's worthwhile, right? It's a worthwhile endeavor. Okay, well, again, thank you so very much for your patience and your attention and your engagement and your good thoughts. I hope to see you guys in the future. And, as I always say when I sign off on my emails, take care and always care well. Have a wonderful day and a great weekend. Bye, guys. Thank you.